So I'm going to echo the comments that have been made for Lucy Haslam and the invitation here. I'm honored to be here among the presenters and to be with you and try to share some of this information. In this particular topic, I don't exactly think it's the most interesting, it's not the most sexy topic that we have, but I'm going to try to spice it up and keep you awake. The things that I think are important, you will see there's a lot of misinformation. I think you've heard that plenty today, that there's a lot of misinformation that comes out in the literature, primarily because the money into this research is designed to look for harm. So moving along, I am now the past president of the Society of Cannabis Clinicians. I gave the position up just about a couple weeks ago. But I've got some really able people that have taken over the president, vice president, two spots in the vice president spot, as well as a new executive director for the Society of Cannabis Clinicians. And I do encourage you to stop by our table display and consider signing up, because there's a wealth of information that's available both in live presentations on a regular basis, as well as on our website, where you're going to find a library. We're loading the library as we go with many of the articles that I'm going to be presenting today, and really as much relevant cannabinoid research as we can find. So I think for brevity, and I thought I might be talking longer, I'm jumping right into this aspect of cannabinoid science, and it has to do with the fact that our cannabinoid systems are not the same from person to person, and you'll probably hear more about this over the weekend. There is a variety of receptors themselves. Now, we speak mostly of the CB1 and the CB2. When we look at the genes that make these receptors, they're not all the same, and it's very interesting to see that they'll cluster within various different cannabinoid deficiencies or differences, I might say. There is variability in the endocannabinoids themselves. There's also significant differences in the variability in the metabolic pathways by which the phytocannabinoids are metabolized. This just notes that the pathways in that cytochrome P450 system that break down THC, CBD, and CBN. This covers 3 of those isoenzymes, the 2C9, the 2C19, and the 3A4. As was mentioned just in Ethan's speech a minute ago, this variability of these isoenzymes is seemingly, in most cases, not particularly significant when it comes to other drugs that are metabolized by these same pathways. So your livers are really quite capable of breaking down more than one drug by that same isoenzyme at any one time. We do see it in this clobazam drug that I'll come to here in a minute. Now, precautions that I like to make aware of to the patients that I'm seeing is that when they start out in cannabis use first time and get into significant use of THC, I'm going to be encouraging them to, as has been mentioned many times, go slowly, start low. Well, nonetheless, some people will experience a significant amount of anxiety and even get to a point of a panic attack. So you want to caution people and perhaps not even start with anything that has any significant THC in it. Maybe go to the type 3 cultivars or chemovars that are predominantly CBD. If you don't get the results you're after, add some THC. Syncope and fall risk is something that I particularly talk about in patients that are elderly, especially if they're using nighttime doses and need to get up at night. Overdoses can easily occur in dabbing, because as in a dab inhalation, you might get a whole joint's worth of cannabinoids in one puff, and has happened many times. People will do such a thing, and then they'll just faint away with this immediate hypotension. They'll faint, they'll fall, and they'll hurt themselves. So I do make a point of cautioning people about that. Smoking cannabis does cause a bronchitis-like condition. There's increase of inflammation, and edema and erythema is the way it's spoken of by Dr. Tashkin, looking into the airway. So it does irritate the airway. Vapor is logically much cleaner and probably should be recommended as an alternative. There is, however, no COPD, no emphysema, and no increase in the cancers of the lung or the airways when smoking cannabis, even in high doses. Cannabis can be habituating, but I say this with some reluctance because it is not an addictive drug. Habituating, if you find something works well for a headache, let's say you take some paracetamol or some aspirin for a headache and it works, and you use that on some kind of a regular basis, does that mean you're addicted to it? No, it really doesn't. Cannabis is a very effective medicine for many kinds of things, and just because you use it, even on a regular basis, doesn't mean you're addicted to it. We've talked a bit already about driving and impaired use of cannabis, and we do have to be careful with that. As people get tolerant of it, then they can tolerate really quite high doses and be quite efficient in these kinds of skills. Drug-drug interactions has been mentioned already, and I won't belabor it here. I do have a couple slides coming up, and I will talk more about schizophrenia and psychosis, as well as this hyperemesis syndrome, the cannabinoid hyperemesis syndrome. Acute adverse effects. Commonly, you may feel woozy, you get high, you feel euphoric, you might have some wooziness to the point of a loss of balance, a dry mouth and dry mucous membranes. Some sleepiness is not uncommon, especially when starting out in cannabis medicine. Forgetfulness is sometimes remarkable early on in the use, but as people again become more tolerant of it, you can't tell that they're under the influence. I would say this especially in reference to so many professionals that I see in my practice, from doctors and lawyers and superior court justices and so forth. They may be using cannabis on a regular basis unimpaired. So this is not necessarily a problem for people that have become familiar with it. Some people never become familiar with it, and just it's not their medicine. The uncommon acute side effects would be some people report a headache. In most cases, it helps headaches. There is nausea and anxiety in some people. There's panic rarely. There's a dysphoria where you don't like the feeling at all and can't wait till it's over. And in some patients, there's a greater feeling of pain. I do hear it rarely, but it does occur. The rare conditions are those such as the acute toxic psychosis. I have not had a patient in over 3,000 patients who actually had this problem, but I have a family friend who did exhibit an acute psychosis. It was a large oral overdose of cannabis, and after about a week, it all cleared up. But it was frightening, and it can occur, but it is, in fact, quite rare. Allergic reactions may occur as well. I have seen it mostly just in topical allergic reactions where people get a red rash when they're around cannabis plants. It's in harvest time or trimming or whatever, and people have to take precautions. As far as a systemic allergic reaction, there may be such a thing. I've heard of it one time. I don't really see it in my own practice, but I think it's something that we have to be aware of could occur. I think it would be less likely to be from the phytocannabinoids and perhaps more likely with the terpenes and some of the other molecules that are there. As far as the chronic cannabis use, there are what I would simply call alleged harms, and then I think we have to pick it apart and look at the evidence to really know what we're talking about. Among these are pulmonary harm, cardiovascular risks, maternal, fetal, and neonatal harm, developing brain, cannabinoid hyperemesis. The question of DNA damage is sometimes spoken of. Addiction, depression, suicide, psychosis and schizophrenia, and the cognitive impairment. So again, this is somewhat going over topics that we've already touched on, but I will run through several of these. The mentor I really look to still for cannabis and pulmonary health is Donald Tashkin. He's Professor Emeritus of Pulmonary Medicine at UCLA. He's still active. He's still on the payroll at NIDA, National Institute on Drug Abuse in Washington. But he has clearly said that smoking can cause irritation of the airway, some inflammation and edema. But besides increased mucus production, and that's about it. There is no COPD, emphysema, or increase in cancers of the larynx, pharynx, esophagus, lungs, and trachea. pulmonary functions tests are slightly different, and this next paper that I reference here that came out in 2013 spoke of marijuana users are more at risk of experiencing respiratory dysfunction, including symptoms of chronic bronchitis, increased mucus production, no surprise, wheezing, which might go along with increased mucus production, and edema of the airway. There's an increased hyperinflation, the FVC, the vital capacity, and the residual lung volumes may also be increased. It doesn't seem to be problematic. It's just that if you take a large group of cannabis users, cannabis smokers, and ask them to take a deep breath for a chest x-ray, they may have a hyperinflated chest. It doesn't mean that they have emphysema. That's not the same thing. But it can affect the pulmonary system in that way. Cardiovascular, there are a number of papers that have come out about this recently. There is vasodilation with cannabinoids. We know that. It does open up blood vessels. It encourages blood flow. So in studies of the brain where you're inducing strokes in lab animals, or in studies of the heart where you're actually inducing a cardiac infarction, the cannabinoids will open those blood vessels and improve perfusion. But there is also some association, rarely, but it's there, for an acute coronary syndrome. So people that have come into emergency rooms, they are being treated for an acute MI. When they report that they've had cannabis within the last hour, you do take note. So I think what might be going on here is that if coronary blood vessels are severely compromised, but a patient is relatively asymptomatic, or maybe they're in denial about their symptoms, I think we have to be careful about recommending cannabis without really going slowly or really getting a workup properly for the coronary arteries. It may be that somebody's got a 95% occluded vessel, and that by getting just a little drop in blood pressure and a little tachycardia, they're not perfusing quite as well, despite the fact that they may be bronchodilating. I'm sorry, that there may be vasodilating. So it's something that I think we have to be aware of. I'm sure more studies will come along. It doesn't seem to be a big problem, but it's something to be aware of. So this is kind of a hot topic, maternal, fetal, and neonatal harm. What does this really mean? The paper that came out in 1995 by Shiono kind of started this off. And Shiono was looking at cocaine and marijuana use in pregnancies and looking for impact on birth outcomes. What were the problems that they would see? And in particular, the data was studied for low birth weight, preterm births, and abruptio placenta. The conclusions of this paper were that marijuana use was relatively common and was not related to adverse pregnancy outcomes. This is in a big N, 7,470 subjects. Cocaine use was uncommon, but was also not related to adverse birth outcomes. Tobacco was, in fact, implicated for what they said was 15% of all cases of low birth weight in this particular study. In more recent times, Hayat Baksh here in Brisbane at the Mater Mothers Hospital looked at a huge group of women coming in for labor and delivery, 24,874 women, 6,500 reported cannabis use, and 2,300 reported regular use, 637 reported use during their pregnancy. So they were looking at multiple measures of harm, low birth weight, preterm births, small for gestational age, and NICU admissions, neonatal intensive care unit admissions, something that sounds a bit scary. And in really many of these measures, they found harm with cannabis use. But we have to take a little closer look at this study. There are limitations to what the conclusions were. The data was derived at the initial visit based on self-reporting without any objective validation. So they're not looking at urine testing, they're not looking at blood testing, they're just taking the patient's word for it. There was no assessment whatsoever of nutritional assessments done as far as what the mothers were getting as far as nutrition. When they were asked that question, have you ever or do you now use illicit drugs? It's felt that they did not really get a good response by many people that may have been using cannabis successfully. So it was felt that there was probably a marked underreporting, and that really limited the subjects that came up positive to not a really representative number of cases. So it is criticized for inaccuracy of self-reporting. You know, if you're going to be doing something that's illegal, and if you're aware of the fact that this could result in legal action and or mother's children being taken into care, many people are simply not going to respond positively about use of cannabis. I do want to speak a moment about just simply low birth weight. Low birth weight is defined as a birth weight below 5 pounds 8 ounces or 2,500 grams, regardless of gestational age. 1 in 12 babies is born with low birth weight. Most low birth weight babies resolve in the first month checkup. Most low birth weight babies are put into NIC units for observation. If you come in and your urine is tested on admission while you're going into labor and you're positive for any drug, your baby may be followed in an intensive care unit for a while just to be sure they're okay. And for opioid-dependent mothers, this is appropriate, as it may be a serious problem for a newborn going through withdrawal. So cannabis babies end up in NICU units, not necessarily because they had anything wrong with them. If the low birth weight is associated with failure to thrive, inability to suckle, or is the result of some more serious medical condition, then it can certainly be a tip-off for something more serious. None of the prominent studies report anything more than lower birth weight. We're not seeing these other birth problems in people using cannabis. Now, the Warshak paper came along in 2015 looking for the association between marijuana use and adverse obstetrical and neonatal outcomes. This was a retrospective study. Cohorts were almost 6,500 women. 6,100 were non-cannabis users and 361 were cannabis users. This came out of Ohio. They evaluated the association of cannabis and adverse obstetrical and neonatal outcomes, and they reported that there was an increased risk in small for gestational age babies as well as NICU admissions. Well, let's take a little look here. One thing was that polysubstance abuse was excluded, which you would expect. So if people came in, they were using opioids and using other drugs, they were not included in this cohort. Alcohol use was not assessed and was not assessed or excluded in this patient population. So women may have been using alcohol on a regular basis and still be included in this cohort. Also, cigarette smoking use was not excluded, and we know full well that lower birth weight and other abnormalities are associated with cigarette use. So it is interesting to note that tobacco occurred in 58% of the marijuana users and only 20% of the non-users. I hope to publish a paper later this year showing that this is not the same relationship I see in my practice. I don't see a lot of tobacco smokers, but I encourage people to really give it up. But it is interesting that so many people are smoking cannabis and smoking tobacco as well. Small for gestational age is not necessarily clinically impactful when you come to these other comorbidities, if you will. And the NICU admissions are not necessarily clinically impactful because of the fact that these studies, number one, don't see any increase in the hospital stay. So they may be looked at maybe overnight, and then the babies go home because they're fine. So that is something that I think warrants a note. Also, the NICU admissions of cannabis or drug-exposed infants may be, again, in these units for mandated by law reasons. So it doesn't really necessarily mean that there's anything wrong with the babies at all. The Connor study came out in 2016. This was a meta-analysis of 31 studies with almost 25,000 subjects. Those were the non-users and 7,800 who reported that they did use cannabis. The pregnancy outcomes that they looked at in this study were low birth weight, preterm birth, small for gestational age, and again, the neonatal intensive care unit admissions, as well as several other measures: stillborns, spontaneous abortions, low APGARs, and abruptio placenta. In the Connor data, in the conclusions, the maternal marijuana use during pregnancy is not an independent risk factor for adverse neonatal outcomes. This is after adjusting for various confounds. The association between maternal marijuana use and adverse outcomes appears attributable to concomitant tobacco use and other confounding variables. So again, we see tobacco coming in as what appears to be the risk factor and not the cannabis use. The gun study came out the same year. This was a study that was assessing the effects of cannabis use on pregnancy, on maternal and fetal outcomes. The source in this case was an evaluation of a huge number of articles, 881 different articles, of which they selected 24 studies that met their inclusion criteria. And in their conclusions, they said that cannabis users increased the odds of anemia in the mothers. It also was associated with lower birth weight, and it was also associated with neonatal intensive care unit admissions. Well, let's take a look at each of these in the gun study to see what we can learn. Number one, anemia. Of the 24 studies that they reviewed, only 6 of them addressed the red blood cell count at all. And of those 6, only 1 of the 24 studies showed some anemia. And what they didn't do is check the blood count when they first were being followed in their prenatal visits. This was at the birth that they were seeing the anemia. So to blame the cannabis as causing the anemia just isn't logical. One study finds anemia but did not include, I'm sorry, I already said that. Most of the studies were unable to exclude polysubstance use, and in order to isolate cannabis, they just were unable to separate cannabis from other drugs. And there was no association found between in utero exposure to cannabis and any other maternal complication. So again, the title, the headlines, the news reports that come out point to anemia, low birth weight, and NICU admissions, but the reality of it is none of these can really be claimed to be true if you're not controlling for tobacco, alcohol, and the fact that babies are put into NICU units if they have been exposed to cannabis. Regarding the lower birth weight, owing to low numbers of studies, this is a quote from the conclusions, that account for concurrent cannabis, alcohol, and tobacco use, studies reporting outcomes of in utero exposure to cannabis in the presence of smoking tobacco and consuming alcohol were included. So again, we're not excluding those with alcohol and tobacco when we're making these conclusions. And in their own conclusions, they admit that the effect of cannabis on maternal and fetal outcomes remain generally unknown. I would counter that. We could say that we generally know that there's no harm. Finally, on again the NICU admissions, there was an increase of NICU admissions. Cannabis exposure for these infants did not extend their hospital stays. Again, laws required observation of illicit drug use, and they did mention too in their conclusions that the APGAR scores were not significantly associated with use of cannabis. Lamaque's study, also 2016. This was a multinational cohort derived from what was known as the SCOPE study, screening for markers of pregnancy complications. Almost 5,600 participants, 313 admitted to cannabis use, where they had 26% of the cohort were tobacco smokers. Cannabis and cigarette smoking status were compared in this study. No association between cannabis use and gestational diabetes, hypertension, or preeclampsia were found. They did find what they called spontaneous preterm births in the cannabis-using group. This was supposedly independent of tobacco smoking. especially after the 20th week of gestation. I want to pick this apart a bit as well. The strength of this study is that it was a large study. The number of spontaneous preterm births was 11 in this 5,600 cohort. 11 cases of spontaneous preterm births. And in my own italics, I've said this is a very small number for spontaneous preterm births that is not found in any of the other studies. Self-reporting issues also become an issue as to whether people are admitting to use of cannabis, and again, people may obscure their use of cannabis to stay out of legal trouble. And there is a need for correcting and making adjustments for the various confounders, BMI, alcohol use, ethnicity, and tobacco smoking. So again, I don't feel that the strengths of this study really implicate cannabis as being causative of spontaneous preterm births. We've heard some mention of the Melanie Dreher work. I think it may have begun as early as the 60s or 70s. This woman is a graduate student at Columbia in anthropology, went to the mountains of Jamaica to study the Rastafarian women. These women were followed in their pregnancies because she knew that many women used cannabis on a regular basis for a number of things. So cannabis, there were 24 prenatal cannabis-exposed newborns and 20 in their control group. No significant differences between the exposed and the non-exposed infants were found at 3 days of age. And at 1 month, the cannabis-exposed newborns showed better physiologic abilities, is what she described. The newborns of heavy marijuana-using mothers had better scores on autonomic stability, quality of alertness, lack of irritability, and self-regulation, and were judged to be more rewarding for the caregivers. Dr. Dreher did go back for years to follow these women and their offspring, and they did very well. And when she went to have that published again by Pediatrics magazine, that she had this initial article published, Pediatrics was not willing to publish it. They simply blew it off and said these were earth mothers, meaning that the women who were smoking marijuana were just better mothers. So it didn't constitute something that they wanted to report. In talking to Dr. Melanie Dreher about this work, she says that the prior study provided a multi-year observational study of the Rastafarian mothers' use of cannabis for themselves and for their children. The Rastafarian women use cannabis for nausea and other discomforts of pregnancy and as a relaxant in labor and delivery. Rastafarians are not polysubstance users or abusers. The women use cannabis on a regular basis as either smoke or tea for themselves for pain, stress, hard work, and monotonous household tasks. And cannabis tea is used by their children, or mothers give the cannabis tea to their children to aid in calming and focusing their preschool and school-age children to widely recognized good effects. So the teachers and the parents are recognizing that giving cannabis tea to the kids seems to be very helpful. To sum this up a bit, there in this National Academy of Sciences report that you've been hearing about that came out 2 years ago, there is substantial evidence of a statistical association between cannabis smoking and low birth weight, but there is only limited, insufficient, or no evidence to support any other health endpoint related to prenatal, perinatal, or neonatal outcomes. So this group, reviewing basically all of the literature since 1999 up until the end of 2016, did not find any significant problems except for the question about slightly lower birth weight. That really was interesting to me in that the mean difference in the weight of these lower birth weight infants was about 100 grams, about 1/4 of a pound is what we're talking about. I'm not really worrying about that. In Itai Babb's work studying bone development under the influence of THC injections in mice, so pregnant mice injected with THC on a daily basis, their bones are a little shorter. And then after they're born and they're no longer exposed to THC, the bone growth rapidly recovers. But babies could be a little bit smaller and perhaps a little bit lower weight if exposed to cannabis throughout the pregnancy. Might be logical to assume. Here's another comment by Nora Volkov, and she is the director of the National Institute on Drug Abuse. This was published in JAMA just a couple years ago. She goes on in this article to say there is cause for concern about women using marijuana. They're more likely to be anemic, they're more likely to have lower birth weight, and they're more likely to require NICU admissions. She's looking at the same studies that I've been reviewing to you, and really, if she were doing her homework, I don't think she would feel right about making these assertions of harm that really don't bear up to more of a critical look at the evidence. What about the developing brain? This too is a hot topic, and most of you would probably raise your hand if you felt that maybe there is some harm in the developing brain. Well, let's look at some of the data here. Short-term memory impairment has been observed after heavy chronic recreational cannabis use, but virtually disappears after a few weeks of abstinence. This has been known for quite a long time. More recent studies are similarly encouraging with regards to the reversibility of cannabis-associated cognitive sequelae. Again, if we're looking at forgetfulness, this is a therapeutic value of cannabis. It gets things off of your mind, and if you're not used to it, you can appear to be kind of spaced out and forgetful. Those who are more accustomed to it, you wouldn't know it, that they're using cannabis. So a lot of it is just a matter of developing tolerance to cannabis. Lower grade point averages associated with persistent cannabis usage in high school pupils lost statistical significance when controlling for concomitant alcohol and tobacco usage. So we're again back to these particular risk factors. And cannabis usage alone was not found responsible for IQ or performance differences in teens compared to cigarette smoking or other confounds. Again, cannabis gets dragged in often because it's not being separated in the study criteria. Now, I want to show you a couple studies that really were focusing on these changes in brain morphology, both the shape and the size of certain brain components. 5 minutes, oh boy. Gilman's data suggests that marijuana exposure, even in young recreational users, is associated with exposure-dependent alterations in neural matrix core reward structures and is consistent with animal studies of changes in dendritic arborization. All this stuff sounds scary, actually. Early exposure to alcohol may have been affecting the brain structure. This was pointed out in the fact that the marijuana smoking youth, adolescents, in this particular study admitted to using more alcohol than the controls. So Weiland was asked to redo this study, also a NIDA-funded study. And she goes on to report that she looked at all of these brain structures, including the nucleus accumbens, the amygdala, and so forth. In the retrospective study examining brain morphology, she went into great lengths to clean this up. So she got 29 adults and 50 adolescents with controls of the same numbers. And the groups were matched. And then they went to look at the results of this. And what they found was, Weiland said that there was no statistical significant differences found between the daily users and non-users on the volume or shape of the regions of interest in the brain. In sum, the results indicate that when carefully controlling for alcohol use, gender, age, and other variables, there is no association between marijuana use and standard volumetric shape measurements of the subcortical structures. In another paper coming out of the Netherlands, similarly, now we're talking about adolescents in a longitudinal study, no significant gray matter changes were observed in the cannabis users. This is an unpublished paper, and again, there was no significant difference in cannabis groups in global or regional brain volumes, cortical thickness or gray matter density, and no significant group by age interactions were found. So I don't think we're really seeing significant brain changes in the cannabis smoking youth. This is a kiddo that I began to see at 16 months of age. It's just an example of a developing brain. He had a large brain tumor. I've showed this to you before in years past. The column on the left is the time that he came to see me at 16 months of age. This is a large optic tract glioma. The parents decided to forego radiation, forego chemotherapy, and just try cannabis. They didn't tell their doctors that they were going to do that, but they did it. And they put cannabis oil, the concentrated oil, on the pacifier twice a day. The mid-morning nap, he'd start giggling after 45 minutes and then fall asleep. And in the evening dose, he'd have a great night's sleep. You see, after 3 months, the tumor is fading. After 5 months, the tumor was gone, basically gone. It was still there, and we have kept this kiddo on cannabis continually. He is on similar doses now as an 8-year-old. I think it's very interesting that when he entered the first grade, they got an IQ test on this kiddo. He's got an IQ of 135. When I sit down and talk with him at least annually, I'm kind of tickled to be able to hear him just talk about all of the interesting things that he's doing in school and talk about his friends. He's a bright little chap. That's primarily THC at bedtime or balanced type 2 at bedtime. They've moved to CBD type 3 in the daytime use. When they started out, it was pretty much high CBD high THC back in 2011. Hyperemesis syndrome, I think it's been touched on a couple times. I think that what's interesting here is that this was first reported in 2004, and the incidence is unknown, but we're certainly seeing it in big city emergency rooms. Most of these people were daily users, half at least. Another almost 24% were using it multiple times a day. When they stop using cannabis, almost all of them return to normal within a couple days. And they do exhibit this compulsive hot bathing that I'll go on about. I don't have a lot of time, but there are some crazy assertions that occur in the literature that come out from our National Institute of Health, suggesting that there's damage to the genetics, that this may be causing all kinds of problems. In the conclusions of this paper, the lay press picks up on this and says this kind of crap. A lot of studies have shown marijuana is not good for you. It can fry the brain and contribute to psychosis. The latest one finds convincing evidence that marijuana smoke damages genetic material, DNA, in ways that could increase the risk of cancer. This is not science, but it is all over our media in the United States. So there's no evidence of genetic damage. In the gun study, they reported no association between cannabis and chromosomal abnormalities. In the Warshak study, they looked at 5,000 cannabis users, and there was no association between cannabis exposure and fetal abnormalities. And even in the National Academy of Science report, there is insufficient evidence to say that there is an association between cannabis and chromosomal abnormalities and fetal malformations. Addiction, we've touched on it before. I think the thing to remember here is in many cases, people are put into treatment programs as a legal mandate to avoid prosecution and incarceration. So it adds to the numbers of people that are seeking treatment programs. They're not necessarily seeking treatment programs. I don't think there's an addiction to cannabis, and my patients think it's laughable when I suggest questions about, do you think you're addicted to cannabis? Depression, we don't have a lot of time left, but I would simply say that many, many patients that I treat for mood disorders have depression and they get relief with using cannabis. Going on from that, there's a paper that came out in 1996 concluding that there are several lines of evidence to suggest that marijuana may possess antidepressant effects, although it is difficult in many reports to be certain that marijuana played a causal role in alleviating depression. The conclusion of the Degenhardt paper, heavy cannabis use may increase depressive symptoms. I think that could be true. For some people, cannabis isn't the best choice if they're depressed. If they're just down and they don't seem to be responding in a good way, it's not for them. But many people do find it really useful. This is my own data on inflammatory bowel disease patients, asking them about depression. The red columns, each pair of columns is each of 38 patients. The red column is without cannabis use. The blue column is the matched column when they are using cannabis. So you can see that in all of these patients, they benefited with the use of cannabis in terms of their mood. So suicide, we currently lack evidence that acute cannabis use increases imminent risk of suicidality. The psychosis and schizophrenia, the one study that I really think tells it all is a big epidemiologic study done in the UK. Two studies are cited here. One of them is the Hickman study, where they looked at the frequency of cannabis use. Over this period of time, from 72 to 02, there was an 18-fold increase in the use of cannabis in 18-year-olds and younger, and a 4-fold increase in the use of adult use of cannabis. While doing this, it was overlaid with the UK study looking at the incidence of psychosis and schizophrenia in the UK health system. So this looked at 2.3% of the UK population over a decade. And during that time, the incidence and prevalence of schizophrenia and psychosis were either stable or declining during that decade. So epidemiologically, it does not really seem to be a causative factor for psychosis and schizophrenia. You look at the news today, it's still in the news. There's association, but it's not a causality matter. Cognition and driving, I think I'm going to skip over this. These studies regarding cognition were done by Fried in 1998. In conclusion, he said prenatal drug exposure accounts for 8% or less of the variance in children's scores in developmental and cognitive tests. There is another study, the MHPCD study, and this also had some deficiencies in the study design. These predictions of both cohorts in this summation here, neither of these NIDA-funded studies excluded polysubstance use or considered environmental and demographic factors associated with academic success. I have 3 slides on driving impairment, and without really reading them, the gist of them is this: that if you're using cannabis and alcohol, you're at a greater risk of accidents. If you're using cannabis alone, there's a very subtle increased risk of accidents. The last study here is that heavy cannabis users develop tolerance to cannabis use, and they may have very high blood levels and still not show impairment. These are studies done by the National Highway Traffic Safety Administration. They report to Congress in the United States about their findings. And this was a bit of a surprise, but I think it's worth noting that people that are regular cannabis users do not exhibit these problems in as far as increased risk of driving accidents. So in final review, millions of people use cannabis with little evidence of harm. There are no deaths from cannabis overdose. There's a paucity of serious adverse effects, and decades of research have failed to show significant and irrefutable harm with cannabis use. Cannabis and cannabinoid research for therapeutic uses remains largely prohibited and unsupported. So this is where I think we really need to be looking, is give up these fortunes that we're putting into searching for harm and begin to help us look for these benefits that we can achieve with cannabis use. So I thank you for your attention.